Good afternoon. My name is Jamie Reed, and I am a clinical research scientist. I am a lifelong Democrat, a mom of 5 boys, 3 of whom were adopted out of the foster care system, and I am a lesbian. I am also the public whistleblower from a pediatric gender center where I was once, like my fellow Democrats, a true believer. I saw patients from the age of 3 until the age of 26, and I worked with nearly 1,500 unique patients. I have lost my clinical research career and my 5 children's college tuitions because I had to follow my ethical clinical training and blow the whistle on these practices. This field is currently harming children, and you will hear from many of those children today who will tell you that they need these interventions to save their lives. That is not true, and I can tell you that from working with this population that what they need is the truth. Many of these young people would simply grow up to be gay if left alone. These interventions themselves are profoundly homophobic and regressive. I live in a state now that has restricted the use of puberty blockers, cross-sex hormones, and surgeries in minors, but these restrictions were too late for my patients. It was too late for my patients who had her breasts surgically removed and called us within 3 months begging for the surgeon to put her breasts back on. Another patient, a young woman we put on testosterone, called our center. She reported that she was bleeding heavily. We told her to put on a thick pad and call us back in an hour if she was still bleeding. She called us back 20 minutes later. She had bled through the pad, her underwear, her blue jeans, the towels she had wrapped around her waist, and her bed comforter, because her vagina experienced a deep, intense laceration that required surgical repair within a children's hospital. Why? Because we put this child on testosterone, which permanently degraded her vaginal canal. We now have an international consensus led by Finland, Sweden, the UK, and countries that Michael Moore would even agree are good liberal places. And these interventions are not supported by evidence. In addition, not all of the US medical associations, which are trade unions, which we should be clear about, they are paid trade unions, do not support these practices. The American Academy of Pediatrics has been sued by harmed patients. They cannot publicly walk this back due to these current lawsuits. Today is International Detransition Day, a day reserved for recognizing and remembering those harmed by these interventions who deserve justice. On this day and every day moving forward, know that we, the adult gays and lesbians, will no longer stay quiet as this homophobic specter robs proto-gay youth of their sexual function and their health. I will forever hold the knowledge that I hurt vulnerable children. I do not want anyone else to carry this pain. We need you to support these bills. I am a medical expert. I am able to answer many of the questions that you have asked the bill representatives earlier, but I urge you, especially those from my own Democratic Party, look at the actual medical evidence and support this bill. Thank you.
All right, we'll go right on to Sandra then, and then we'll ask questions. Thank you.
Good afternoon. My name is Sandra Asuncion. I'm the Director of Government Affairs at American Principles Project, a pro-family organization based out of Virginia. I'm proud to be here in support of AB 104, a bill that will protect children from undergoing debilitating procedures that do nothing to address the source of their ailments, pre-existing conditions, or comorbidities. Minors are not prepared to make life-altering decisions. That's why we don't even allow them to get a tattoo. A child undergoing the discomfort of puberty will not have the presence of mind to understand the full consequences of chemically altering that process, especially since our own scientists have yet to issue a comprehensive and cohesive study on the subject. There's no medical gold standard for prescribing puberty blockers, hormone treatments, and surgeries to minors. In fact, many countries that were once lauding these procedures are now pulling back and tightening restrictions. According to one study, quote, longitudinal data collected and analyzed by public health authorities in Finland, Sweden, the Netherlands, and England have concluded that the risk-benefit ratio of gender transition for youth ranges from unknown to unfavorable, end quote. And according to research by Dr. James Cantor, up to 90% of children who suffer from gender dysphoria resolve those feelings by the time they reach adulthood if they are not transitioned. What can be shown concretely are the many negative and painful side effects resulting from the transition process. Puberty blockers like Lupron cause premature osteoporosis in teens, which leads to fragile bones, slipped hips, and other injuries typically associated with the elderly. Couple that with cross-sex hormones, they're sterilizing, and the surgeries leave lifelong wounds that will never fully heal. Added to the negative physical outcomes, there is a mental health crisis too. Risk of suicide is a constant threat used to pressure parents into transitioning their child. But a recent study from Texas University showed worse mental health outcomes and higher suicidality rates in patients who transitioned. Gender dysphoric males saw their rate of depression more than double after transition surgery when compared to their non-surgically transitioned peers, and anxiety skyrocketed nearly 5 times higher. Another report from 2023 showed that transitioned adults were actually 19 times more likely to commit suicide, with that number escalating for transitioned females to 40 times that of their peers. Many experiencing gender dysphoria are also struggling with other mental health challenges such as autism, anxiety, and depression. Still, others have been victims of sexual assault. And yet the standard of care they are told to expect and embrace is one that ignores those mental struggles and instead maims their physically healthy bodies. Medicine should correct an ailment so the full body can function at its greatest capacity. It shouldn't maim healthy organs to suit the sickness. We need to protect these children when they're at these pivotal and uncomfortable times in their lives. This is when they need our strongest support. And right now the problem is so endemic they need it not just from their parents and loved ones, but also from their legislature. Wisconsin would not be an outlier in signing this bill. There are 26 other states that have already passed similar laws, and we've seen at least 33 nations across 4 continents ban these procedures for minors. And I hope the rest of our nation is not far behind. I appreciate the committee dedicating their time to this bill, and on behalf of AVP, I urge you to support the passage of AB 104. Thank you.
All right. Thank you for your testimony. I'll start with Representative Wickers and then Representative Brooks.
Thank you for your testimony. Was there a moment where you used to speak one language and then you changed how you spoke and now you're speaking like you speak now? And was it the science? Was it the witness? What part changed? And then is there anything in your testimony that you wanted to say that you weren't able to say as a result of, you said there's questions that you could answer?
Thank you, Representative, for the question. Yes, I was once an absolute true believer. I trained judges within the state of Missouri around gender-affirming care. I trained all of the other divisions within the hospital setting around what is referred to as gender-affirming care. I believed wholeheartedly in this protocol. My spouse is trans, who has now walked back her transition. She was trans for 13 years. There were 3 aspects that made me come to change my mind. Number 1, this protocol itself was built on regressive stereotypes and is homophobic. The first 70 children that were put through this protocol, 68 of them were same-sex attracted. The entire DSM protocol is based on stereotypes about what sexed behavior looks like, and most gays and lesbians in childhood do not fit the mold of what regressive stereotypes look like for sexed behavior. Of the 71st children that were put through this protocol, 1 of them died because the protocol itself destroyed what used to be the way that we would invert an adult's penis to make it a vagina. The puberty blocker itself makes the penis not grow to the point where that child was put through a vaginoplasty that used their colon instead, and they died of a massive infection. The protocol itself is homophobic. Number 2, I saw a patient population go from 4 new intakes per month of children who are mostly pre-pubertal boys to 50 to 60 new patients per month, and 80% of them were teenage girls. Guess what teenage girls have in common? They are absolutely susceptible to social contagion. This occurred right when COVID lockdowns happened, right when we stuck one of these in all of those teenagers' phones, and right when we saw all of these girls watching videos. We actually referred to it in the clinic as TikTok tics. They literally were parroting and coming into our clinic with the exact same storyline that they learned online about what it meant to be trans. And then third and finally was that I actually harmed patients. This protocol itself physically harmed my patients. to the point where I was sending children to the emergency room for emergency surgeries after they had their first sexual experience and their vaginas were ripping open. We removed the breast of a young woman who called us back begging to have them put on. She not only had detransitioned and was re-identifying as a woman, she was also pregnant. She also grew up in foster care, and she literally told us that part of this identity for her was a social contagion. So I absolutely had to change my mind because ethically it is the only right thing to do. And I beg my party, please do the scientific right thing. Thank you.
Representative Brooks.
Thank you for your testimony. A couple of questions, if I can, Mr. Chair.
Two.
Thank you. The phrase of the day seems to be this life-affirming care. I keep pointing out in the bill that if it's a medical necessity, surgery's okay, that's okay. Do you think not prescribing hormones or puberty blockers is an automatic imminent danger of death or impairment? Yes or no?
Absolutely not. There's no medical need for an emergent situation where any child or young person needs to be prescribed a puberty blocker or cross-sex hormones. We have absolutely good, solid, scientific ways to address suicidality in children. We know how to do it in every other circumstance. There is absolutely also no scientific evidence to prove that these interventions treat suicidality. Canada released 2 evidence-based systematic reviews last month on puberty blockers and cross-sex hormones. They asked that exact question. Do these interventions reduce suicidality or mental health issues? Both of those systematic reviews found no evidence to support these interventions being directly correlated with a reduction in suicidality or an improvement in mental health. In fact, Dr. Annalou de Vries, the woman, one of the 3 mental health providers in the Netherlands who came up with this idea, released a paper 2 months ago where she even acknowledged that there is no evidence to support that these interventions are treating mental health conditions.
My follow-up question and a half is, do puberty blockers in conjunction with hormone treatment cause sterility?
They do, and which is why I believe it is a human rights abuse against proto-gay youth. I believe that we are currently sterilizing proto-gay youth, and I believe we are committing an international human rights abuse against these children.
Is that a medical certainty?
That is-
Is there
so-
another doctor that would come up here today and argue that point, that puberty blockers in conjunction with sexual hormone treatment does not cause long-term permanent damage to the reproductive system?
Thank you for the follow-up, and I will clarify. If I give a natal boy, a boy born with a penis and and testicles, a puberty blocker at Tanner stage 2, this is when the protocol designed itself to be given at Tanner stage 2. If I give a puberty blocker to a natal boy at Tanner stage 2, when I'm supposed to, their testicles will never develop, their penis will not grow, they will not develop the pathways to make sperm. Women are born with all of the eggs in their body that they will ever have. It is a statistical guarantee, if I follow the protocol correctly with a boy, give them a puberty blocker at Tanner stage 2, give them cross-sex hormones between the ages of 13 and 16, it is a statistical guarantee that I will sterilize them. I will also tell you that hypothetically what we discussed is one of the possibilities of preserving fertility for these boys would be to surgically remove a portion of their testicle tissue, freeze it, and then later implant that tissue into the abdomen to see if we could revascularize it and bring it back to possibly maybe produce sperm later. It is a known pathway, if we give this to boys at Tanner 2 and then a cross-sex hormone, they are sterile for the rest of their life. We do not have the legal right to sterilize children in this country, especially proto-gay youth.
So I just want to reiterate, you believe that to be a medical certainty, that those two things in conjunction sterilize children?
I don't believe it. I assisted in the fertility preservation conversations. I assisted in fertility preservation when it came to some of the girls. And it is known, the endocrinologist will tell you, if you give a boy at Tanner stage 2 a puberty blocker and then a cross-sex hormone, they will be sterile.
So you are a physician.
No, I have a master's of science in
All right.
clinical research management. I'm a clinical research coordinator. I've run clinical research trials in bone marrow transplants and hematology, oncology, endocrinology, and I've worked at a medical university.
Okay. I guess my question for you, even though you're not a doctor of medicine, would this, a parent coming forward with a request to sterilize their child pass the litmus test for do no harm under the oath you take as a physician, knowing that that is the case? To me, that flies in the face of your Hippocratic oath to do no harm if you know you are sterilizing a child that's under 18 and there is no imminent danger of death or impairment by doing so. I mean, you're not preventing death or impairment by doing those treatments.
You are
Mr.
not.
Chairman,
Other
point
than-
of order, she said she's not a doctor, correct?
Okay, I have the floor.
Yeah.
Yeah, and nor are you. Nor am I, that's why I asked the question, Representative.
Thank you for the question. I will add, I have been certified in multiple states as an expert in this field and in this area. I also have extensive training in medical ethics and consent. And so, yes, one of the big pathways here is talking about, do parents have the ability to consent for this? Parents do not have the ability to consent for this. And I will also say, as a lesbian, I do not believe we would have ever gotten to the point where we are now if it weren't for underlying homophobia. This protocol was started on proto-gay children because it was okay to experiment on kids like me because we do not fit the norms of sex-based stereotypes. This kind of protocol would never have gotten to the point where it is now if it not for homophobia.
And Representative Johnson, I'm sorry for snapping at you. But I asked the question if she was a doctor because I wasn't sure, and I encourage every physician that's going to come up later today, if they have a contradictory statement, I would love to hear that. That was my point. That's why I asked the question. And I apologize for snapping at you.
You asked about Hippocratic oath to someone who is not a doctor. That was why I asked
Okay.
the point of clarification.
Yep. Thank you.
Representative Subek.
I think my question has actually been answered. I was going to ask if Jamie was a licensed medical provider here in Wisconsin or any other state. I think we've established that she's not, so I'm good. Thank you.
I was actually going to ask that too, but I'm curious because you brought this up, and as a healthcare provider, as a doctor, even though the last campaign they said I was not, I'm a doctor of chiropractic who addresses a lot of musculoskeletal issues. So for me to diagnose conditions, it's easy. It's very objective, orthopedic tests, range of motion tests, a little bit of patient feedback. Gender dysphoria, we keep hearing about how it's diagnosed. I think I'm directing this question at Jamie. How do they diagnose that as a physician, gender dysphoria? Because it seems very subjective, like patient reported. How physically, if they come in with one set of anatomy and the person standing before you, how do you objectively diagnose that?
Thank you for the question. There is no objective test for this. There is a checklist in the DSM-5. That checklist includes, directly from the DSM-5, in boys, a strong preference for cross-dressing or simulating female attire, or in girls, a strong preference for wearing only typical masculine clothing and a strong resistance to wearing of typical female clothing. Guess what? Gay children do this. Proto-gay children do this. A strong preference for cross-gender roles in make-believe play or fantasy. in toys and games. So if I chose Legos instead of Barbies, which I did, the DSM-5 would be able to go through this checklist and declare that I would have fit all of the criteria for gender dysphoria in early childhood. Almost every adult gay and lesbian that I read the DSM-5 checklist to on gender dysphoria will report that they meet almost every single element of the criteria. This is profoundly regressive and homophobic. We have no way to determine which children will grow up to be gay and which children will grow up to have lifetime distress regarding their sexed bodies. I do not deny that some children will grow up to have lifetime distress around their sexed bodies, but we have no way to know the difference.
Thank you. Representative Gundrum.
Thank you, Mr. Chair. I just need a clarification on a couple of things. You mentioned proto-gay. What does that mean in layman's terms?
Thank you. That's a really good question. I don't believe that we should be prescribing a sexual orientation onto a child.
Okay.
So children should not be sexual beings. They are children. But we all know, all of us know, the little boys who like to wrap the towel around their head and like to put on mom's shoes. These are what we would refer to as proto-gay instances in early childhood. I had many of them. I was what is referred to as a tomboy. That is what we see in proto-gay youth. It is a way to clinically describe behaviors without ascribing sexual orientation onto children.
Okay, and then the other clarification I need, when you talked about a boy being made sterile, you said in stage 2 something, I can't remember the word, but can you clarify what that means?
Yes, so Tanner staging is the endocrinologist's way of devising essentially where someone is at in puberty. This protocol was created thinking that we would intervene at Tanner stage 2. The whole reason why this protocol was created for children was because the transsexual adults, so men who grew up and wanted to be seen as women, could not pass. We had a choice then. We could have decided as a society to make room for individuals who want to appear as female but do not pass in society. We could have made room for them then and expanded our horizons on how we embrace people who are not following stereotypes of sex. Instead of doing that, they went back and tried to change the bodies of children. And so they ascribed the protocol to start then, before some of those secondary sex characteristics would develop in the boys, like the Adam's apple, the shoulder developing, height. They tried to intervene then so that these men would not look like men later, that they could pass better as female. It was actually basically purely cosmetic as well, why this protocol was developed.
Thank you. Thank you for testifying. I'm glad that you were here to present your case. It's been very helpful.
Thank you.
Representative Wickers.
Yes, over here. A follow-up to my first question that you gave the first half of the answer, and the reference is the doctor that spoke earlier made a brief statement. If you could dive a little deeper and give a little more clarity. And the blanket statement that was given was, in the world medical community, they've determined that the longer you wait to do the surgery, the more successful the surgeries will be and the less harm there would be to the, this bill is about minor children. So you mentioned in the first part of my first question, just so you can get caught up where we were, is that there was somebody that you saw that died because the process that child was under at that time didn't let the child develop fully, and it ended up in death. So it was leading to the question, the doctor said, wait and let these minor children wait until their bodies are fully developed and the therapies are taking hold, and they're going to have greater success to their trans surgeries. If you could dive a little deeper on that science, if you can.
I can. But the problem here becomes, are we talking about natal boys or natal girls? So natal boys' vaginoplasties, so that's the creation of a neovagina with a penis, will have better outcomes if you wait until they are adults to invert that penile tissue, because they will have enough tissue to create the neovagina. However, we should be honest, that is a very difficult surgery that has high rates of a lot of problems. And regardless of what length of time you allow that penile tissue to develop, it still is a surgery with a lot of known problems. One of the arguments that the other side will make is that it's better to intervene earlier with the girls because it will mean that they might not have to have one surgery later. That is what is colloquially referred to as top surgery. So when I was on the other side of this issue, I would argue it's better to intervene in these girls early so that it could save them from having top surgery later. The issue is, data-wise, most of these girls do not show up in a gender clinic until they're between the ages of 15 and 17. They've already been through puberty. Their chest tissue already developed. The argument that it's better to intervene earlier in the girls to save them from that surgery later just doesn't play out in the data. They don't show up in these clinics until the highest rate of the kids that we saw show up in my clinic were age 16. They were girls. There's also a major concern that they are in the midst of a huge social contagion. The reason why we're talking about this at all is because we've seen a huge explosion of the identity of trans. But yes, there's different surgical pathways depending if you're talking about a natal boy or a natal girl. Either way, there is true arguments that children cannot consent to lifelong procedures that will remove their fertility, make their endocrine system not function, and remove their sexual function.